Oh my, have we got a case for y'all? This is going to be so exciting in every kind of TMAR fashion, of course, right? They're always exciting. Today we have a case by Alvin. And so let's get started. I wrote down some of the HPI for us already. This lady that we're talking about today is 64. She has a history of a stroke and hypertension. Alvin tells me she came in initially with shortness of breath and right upper extremity weakness. The symptoms started 1 day prior to admission. They had started abruptly. She also noted concurrent exertional worsening of her shortness of breath, orthopnea, and PND. She couldn't sleep overnight, so she came into the ED, and then in the ED is where she noted, and they noted, that she had this right upper extremity weakness. Meds, she's just on aspirin. Socially, she's a smoker. She has no family history. Let's do some quick solicitation of questions, HPAC clarification from y'all, and then we'll head into some labs.
Does she have weakness anywhere else?
Alvin? I think I heard pain. Okay, so no chest pain, or I guess arm pain. What else? Anything else, y'all? Oh, the chat. Yeah. Weakness anywhere else or changes in sensation? What fantastic questions.
Weakness is only on the right upper extremity. No identifiable weakness elsewhere. She is somewhat altered on presentation as well, so it's a little hard to get her to participate in exam.
No other weakness, and then she had altered mental status.
Where were her prior strokes, or what were her old deficits?
What was Cyrus? That's your son's name.
Prior stroke symptoms.
Oh, what was her prior stroke? We do not know. This is unknown. Vision changes? Any deficits from prior stroke? No and no. No deficits, and we don't really know what her prior CVA was all about. And this is from a PA student, so you guys all know they're pretty good. Visuals changes, how is she altered? Is she coherent?
She's altered. She
just can't.
She says nonsensical.
Okay.
Doesn't really, not really reorient.
Okay, like a word salad kind of thing? Okay, or just like nonsense. All right. How acute onset was the right upper extremity weakness? They noted it happened before their very eyes, Andy. Right before their eyes.
The son called an ambulance for the shortness of breath.
Yeah.
He didn't go with them to the ED.
Uh-huh.
In the ED, they were examining her and they were like, shit, her right upper extremity is now.
Oh my. I think I already know. Anyways, I'm so excited. In any case.
What about the ultimate?
Seems to have gotten worse. She was
oh, wow.
Breathe, when they called the ambulance, and then when she was in the ED, she wasn't really responding with any questions.
Joey asks, any rash?
No rash that they saw.
No rashes, okay.
What are they saw?
Okay. Oh, Shuji Kikimasen. Oh, I see. Alvin is the person you can't hear. Of course you can hear me. Yes, he says that there's no rash that they could see. And hopefully the rest of it you could hear. But we'll ask Alvin to speak a little louder too. All right, anything else for HPI, or should we go on to some objective data? All right, Alvin, give me that beautiful exam that you did.
So she has diffuse crackles
Okay.
bilaterally. She is moderately tachypnic. Doesn't have any new murmurs, but she does have an S3.
Regular rate and rhythm?
Regular rate and rhythm.
Regular rate and rhythm. Positive S3.
The abdomen's fine. She withdraws to
No
pain.
hepatosplenomegaly?
Not that I could appreciate, but
Okay.
that's not saying much.
So we'll just say soft, non-tender, non-distended.
She doesn't. She has a little bit of lower extremity edema. I'd say like 1 to 2 plus.
Okay, legs, they're looking fine.
And then as far as her neuro exam goes, she withdraws to pain
Uh-huh.
on bilateral lower extremities.
Uh-huh.
She can't. She was, like altered, so kind of
Uh-huh.
kicking away at people. So she had good strength in there.
Uh-huh.
The right upper extremity, she does not withdraw to pain. It drops if you lift it up. She's not really able to squeeze her hand when you ask her to. The left upper extremity, she was able to actually do those things.
Okay.
And sensation, as far as we can tell, was fine, but again, difficult to assess given her mental status.
Okay. Sensory intact. Hopefully people can read whatever that is. And then, all right, so hopefully, Alvin says diffuse crackles, increased respiratory rate, regular rate and rhythm, positive S3, abdomen is soft, non-tender, non-distended, legs are fine with maybe a little bit of lower extremity edema. And then neuro exam, she does withdraw to pain. Her legs, she's kicking. She's got 5 out of 5 strength. She's altered a little bit. She does have her known right upper extremity weakness. It drops. She can't use it at all. She's got 0 to 5 strength. Left upper extremity is fine, though. It's 5 out of 5. And from what they could tell, her sensory was intact, but she's altered, so they weren't able to get great participation in the exam.
A&O time.
Okay, A&O times 1 to 2, let's say. And then Joey asks, was the face asymmetric?
No.
And then can we get some vitals? Yes, of course we can.
Vitals. So afebrile, low 100s heart rate, breathing in the 20s, blood pressure of about 160 over time, and satting like 92% on room air.
All right, Alvin, why don't you also give us the some basic labs.
Oh, and then this question, pulses equal everywhere.
Oh, Mark asks, were the pulses equal everywhere?
Yes.
And I think Joey, she does not follow commands.
Basic lab. So her BNP, or BMP, I should say,
Sure.
was fine. She had a little bit of an AKI, about 1.8.
Normal with a creatinine, 1.8. Do we know what her baseline is?
Presumably normal.
Okay, from normal. Okay.
Her CBC, hemoglobin at 13.2.
Yeah.
Platelets of 11.
Ooh.
And normal.
What is her hemoglobin?
Hemoglobin 6.
Oh, this one's 13.
Yeah, the white
I see. And this one was normal. Okay.
And we didn't get LFTs. Tropes were 5,976, and then 2 hours later it was 6,890.
That's not good. Do we get a BNP?
About 15.
Okay. And I'm guessing there was probably a CT down of the head.
And the CT of the head showed some old implants, but nothing new.
Oh,
So neuro got involved, and they got an MRI.
Okay.
And that showed new areas of acute and subacute ischemia.
New acute plus subacute stroke. Where was it? Did they say?
I don't have that information.
information. Sorry.
Sorry, we do not have that information. Okay.
The only last thing, what was it? Volume exam, DVD, she's
Okay.
Did everyone hear that?
Let me
Keep
see
volume
here.
up.
But I'll put it over here and we'll say increase volume. Positive JVD. All right. Jugular reflex. Okay. All right. I am going to break you guys into groups, but I'm telling you now, it's not going to be a lot of time. It's 8:01 now. I'll probably call you back within 3 minutes.
Give more. Give more.
How many people do we have?
So wait, now you want to do differential for the workup?
That's what they're going to do. So yeah, come back with your differential diagnosis. Next workup.
Are we not getting an
an
EKG?
Oh, EKG.
It's not.
Normal EKG. All right. We'll make you into 4 groups. I'll see you guys back in 3 to 5 minutes.
Don't tell us what it is though.
No,
Yeah.
it's just
I
this started out as for them. It started
get out of here, Candace.
It started out as like nuance of heart failure and STEMI.
Yeah.
Need a catheter, and then her platelets came back at 11, and they were like, the platelets are 11, and she has no strokes, and we can't have her either. We can't catheter, and then that sent her down this path. To this day, her cardiac history has not been figured out because no one's had enough time to actually go and investigate because the platelets have been such a long time.
You know what I'm thinking? Altered mental status. Stroke.
Yeah.
New platelets.
TTP.
Yeah, 100%.
That's kind of what I was thinking about. Which we didn't get that not workup.
Yeah.
This is from the initial admission that we had.
Did she have a smear there?
Okay. But this from the first admission, I got her after the second admission, so I had to summarize all of this, and then she came back because her platelets. So it was TTP when she first got
got it.
Her Adams TS13 that they checked was. She got plasmapheresis, she got steroids. Her platelets came up, sustained over 150. She went to rehab, and then she had follow-up labs, and her platelets were back down at 11.
Any new drugs?
No, they added on Plavix, or no, they didn't have Plavix, sorry. They added on Tope and a stat for her new cardiomyopathy, but aside from that, she was on steroid taper.
She was still on steroids and the platelets came back at, you said 11?
She's at the tail end of her.
Any signs of infection?
So we expect those to infect.
So, probably,
Probably, but you know.
So they treated it
But
as
she was
still
still
plasmapheresis. Her platelets are getting better, and then they came right back down. And while she was getting plasmapheresis, they gave her Rituxan, and she still kept going.
Oh shit.
Then her Adams TS13 came back at like 75%.
Yeah.
when they treated her for recurrent TTP, did she have schistocytes? Okay. Then it could have been schistocytes. And then when they dropped again, did she still have schistocytes?
There's only a couple of scans that were in the
I guess what I would ask is when she came here, they retransferred her, it sounds like, because they tried to treat for TTP and it wasn't working. So when they did the smear here, they see schistocytes.
They went as far as got bone marrow.
Okay.
But I remember the first 2 smears that she had.
How anemic did she become?
I'm sorry, I don't remember.
Did you get an answer? Like, yeah,
You can.
I mean,
Yeah.
you have thrombosis now. I mean, it's just like,
Yeah, it's true.
that's a lot.
Her anemia got down to 6 to 8. She kind of hovered around.
Yeah, that makes sense. Makes a lot of sense.
What's y'all now? Green.
Green 1 or green 2?
And
Lorna Monks.
the monks here. What are we looking at?
All right, it's 8:06. They've had 5 minutes. Should I bring them back?
Yeah, let's just find. Let me just find that spear.
All right. They'll have a minute when I hit closing.
What are we looking at? Where did you come in?
She came here on the 31st.
For spear. 331. Don't see shit.
Yeah, it's not TTP.
So they don't get it.
They don't think it's TTP now.
Yeah.
But it was.
It was. And they repeated her out of the search a couple of times and it's come back. I think most recently.
Here we go. One possibility. Because a lot. What was like, how good is 1+, you know?
All right. Welcome back, y'all. Where did my participants go? There we go. I hope that was a riveting discussion. All right. So let's just go by group and see what we came up with. We have group 1. I'd like to get a little some diagnosis, some workup action, maybe some management decisions. All right, group 1, I have Akil, Carissa, Kathy, Mark, and Rashi. Both Kathys in one group. What serendipity? So anybody from group 1, let me know what you guys were thinking is going on.
We were talking mostly about Takayasu arteritis and TTP. So we want ESR CRP, maybe an MRA to go with our MRI, and a blood smear,
Okay, so TTP.
and a Navi consult.
Takayasu arteritis. You want a smear. You want a Navi. And what else was there?
If we could go back in time and get an MRA with our MRI, that would be nice.
I see. Okay. The MRI. And what do you want to do with the patient?
What do you mean?
How are we managing this encephalopathic being?
I mean, I guess if the smear shows hemolysis and she needs pheresis. But
very good. Yeah. So question. Pheresis. Agreed. Okay. Group 2 is Akanksha, Allison, Amanda, AAA, Matt, and Shuji-san. What do you guys got?
So, like as in the group, I think TTP is one of the differential we have because of the AKI, thrombocytopenia, and the neurological deficits.
Okay.
Down to 11. So TTP was like pretty high on our list. So I think, yeah, getting a smear is good. And then there's some component of the heart failure that's so we would like to get echo. Other differential we thought was that maybe he had a PE that had a PFO that had caused neurological deficits. I think getting an echocardiogram is like definitely important. And smear and I don't know,
Okay.
like management, yeah, plasmapheresis, but if he does look fluid overload, maybe give some diuretics.
Okay. Got it. Love it. Breakout group 3 is the venerable Anita Molai, or Anahita actually is how you say it, Danielle Verghese, Grant, the Jerka, Jillian Cooper, Katie, and Kara Paul. What do you guys got?
So we also had TTP, high on the
Okay.
differential.
Love it.
No other workup for that wasn't mentioned or management. And then we also thought about merantic or non-infectious endocarditis.
Oh, interesting. Endocarditis. Merantic, which is non-infectious, sure. Okay.
And yeah, that's about
All
it.
right, cool. Anything different you guys want to do for workup and management? And maybe it sounds like perhaps some cultures, although you're leaning towards a non-infectious endocarditis.
Yeah.
Okay.
We get grab cultures, sure.
Yeah, I think so too.
Why not? For completeness sake.
Cultures are sexy. They're in. Breakout room 4 is Andy, Candace, Ellie, Joey, Rahid, and Ronnie.
So we're putting all our money on COVID. Some myocarditis action, a bit of ITP from the COVID, and some clots in the brain from the COVID. Our workup is COVID swab.
Okay.
And
chest X-ray.
Love it. Okay.
Consult ID for some REM and DEX.
All right. So ID, consider RAM Dex. Love it. Okay. Before we move on, it sounds like a good chunk of us were thinking TTP. And so TTP is one of those kind of like very, I guess I could say, emergent diagnoses to make. You have to decide if it's TTP or not pretty quickly before you move on. And it sounds like, at least when it came to the TTP, what kind of drew everybody towards that direction from her initial like workup?
Well, we noticed the thrombocytopenia, but without anemia, without fever, we were thinking more of ITP.
Okay.
Because we weren't seeing a hemolysis picture.
Sure. That's definitely fair. It would have been cool to have some hemolysis labs, I agree. And sometimes that hemoglobin is not so reliable, but yeah, I agree. And then so without evidence of hemolysis, then it looks like you were leaning towards ITP. So then what swayed you back towards TTP?
Her neurologic abnormalities tied in well to that. I know we have the evidence of it in the on the MRI, but
yeah,
that plus the profound thrombocytopenia were pretty hard to ignore.
Yeah. So I think what Katie's getting to is this TTP pentad that we usually see. So the two most components, because to be honest, this pentad is only seen in about like 5 to 10% of people. The two most components when you're evaluating somebody for TTP, and the only reason I'm going over this is because it's an emergency diagnosis, you don't want to miss this, is evidence of MAHA with thrombocytopenia. The way I remember kind of like the three components that are the most important to myself is, TTP, T for like thrombotic microangiopathy, the other T for thrombocytopenia. And then this purpura just reminds me of like end organ, like damage, purpura in the brains, purpura in the kidney, purpura in some sort of organ, right? So the finish off the pentad, usually people see fever, AKI, and stroke or seizure, or like altered mental status, encephalopathy. Of these like kind of co-associated symptoms, this altered mental status is seen in up to like I believe 60% of people. Fever is only seen in like probably less than a quarter. AKI is probably also seen in about 50% of people. And altogether, the pentad is only in about 5% of people. But when it comes to the evaluation of TTP, what test, and it's not mentioned here, how do you confirm your diagnosis? And do you need to confirm your diagnosis before you start treating them? I'll say this, the confirmatory test is related to the mechanism of TTP.
Is it the Adam T13? Whatever
Oh, yes. Yes, so Candace, exactly. exactly. So everybody got it right. So the confirmatory test is checking an Adam TS13, and not just a activity, but also you check for an inhibitor, and then you also check for antibodies all at the same time, and typically these are IgG. And a positive test is if like an activity is less than 10%, or if there is an inhibitor, or if there are antibodies. The problem that everybody, as they mentioned, is this test takes forever to come back. And the problem with TTP is it will kill you. So in patients that have unexplained MAHA and thrombocytopenia, you don't know why this is happening, this alone is an indication to start pheresis, because otherwise it'll kill them. So obviously we know that the first step in management for a suspected TTP is plasma pheresis. And the reason for that is this Adam TS13, it's normally supposed to cut up von Willebrand factor. And so when von Willebrand factor is left to its own devices, these giant multimers are just floating around in your blood, and then platelets start aggregating on them. And you can imagine if this is happening essentially everywhere in your body, and inappropriately, you're going to create microthrombi, and those microthrombi will then accumulate and cause end organ damage. Adam TS13 is supposed to break this up into little pieces and then prevent this from happening. So that's why it's like kind of thrombogenic. All right, so the first thing is plasmapheresis, and the reason for that is you're going to try to remove the antibodies if they exist to Adam TS13, inhibitors if they exist, and then also these multimers, and then replace it with normal plasma that should have Adam TS13 in it, and you know, that way your von Willebrand factors will be kind of broken up. What additional therapy do we add to plasmapheresis? How else do we control antibodies? Yes, Rashi, very good. So when it comes to anything that is like an immune response, we worry about that immune response becoming out of control. So we give them steroids. And these are pretty high dose, actually. You can give up to like a gram of methylpred for 3 days, typically, I think is like the ASH guideline. And then in addition to that, what creates antibodies? And I'm hearing, actually, I'm almost deafened by the entirety of all of you at the same time shouting out to me, CD positive, CD20 positive, B in plasma cells. So you got to inhibit those puppies, and you're going to inhibit with, Kirpal is absolutely right, rituximab, which is a CD20 antagonist, right? So this, at least mechanistically now, makes sense for the treatment of PTP. A very interesting diagnosis to go down. All right, any questions about that? I'm going to now move on to the meat of our talk today, which is an approach to thrombocytopenia. And what I'll say about my approach to thrombocytopenia and generally approaches to thrombocytopenia is I think people usually teach this as like, hey, there's like anemia, very simple, you know, differential. You can either have decreased production, or you can have increased destruction. And same thing with platelets, right? Usually people learn this like decreased production or increased destruction. The only problem I have with these differentials, they were great for me as a medical student because it allowed me to kind of like remember all of the things that caused thrombocytopenia, but it just didn't give me a good way to apply that differential to the patient in front of me. It didn't give me like kind of like an approach. It didn't give me like a way to think about what's more likely, less likely, without having to recall everything that's going on with the patient. So the way I like to explore thrombocytopenia is it really hinges on a peripheral blood smear. So in any patient that has decreased platelets, there's a few kind of like stepwise things that we do first. So anybody who has decreased platelets, you may want to consider repeating the test first and doing this on a either a citrated or heparinized tube. And the reason for that is because the typical ethylene diamine tetraacetic acid or EDTA tubes tend to cause platelet clumping. So to prevent that, we do repeat it. All right, so let's say we have a confirmed low platelet. The way I think about now with my low platelets is there's really kind of like two main branches. One of them is going to be, like low platelets with essentially like anemia. WBC involvement. And then finally, low platelets without anemia. So typically like, so without, or like I'll just say here, I'll just say isolated low platelets. I'm just doing a downward arrow and a P for now because thrombocytopenia takes me too long to write out. And then this branch over here will be essentially with like an abnormal CBC. So this branch. Maybe we'll do something like that. And cut this out here. Do a little eraser action. Oops. Yeah, that'll work. That'll work. I'm not a typical flowchart kind of guy, so I'm kind of making this up as I go. All right. So when it comes to anemia, so thrombocytopenia with other CBC abnormalities, the most common like other cell that I think of that gets affected by, thrombocytopenia and like the same mechanisms is, like I said, anemia and thrombocytopenia, at least mechanistically speaking, are always very closely associated. What the next step in evaluation of thrombocytopenia is always, after repeating it, is to get a blood smear. And then when we look at the blood smear, we look at the other cell lines, and especially the RBCs, to see what's going on with them to help us decide, what's going on with the patient. So when it comes to the red blood cells, a few findings, and I'm going to list like kind of most of them. You can have overlap with these findings, but I'm going to list the most important finding that's going to help you narrow your differential, right? So the first and foremost, the most dangerous thing that we always look for with thrombocytopenia is schistocytes. The next thing to think about are spherocytes and dacrocytes. Schistocytes is like those little helmet cells, like fragments of RBCs. Spherocytes are when the biconcave disc instead starts looking like this balloon, or sorry, it should be smaller. And it's like a spherical cell. And dacrocytes are those teardrop cells. The other things to think about are WBC abnormalities. What's the word I'm looking for? Like inclusions. And then, of course, for your, I'll actually put this over here. And then for your isolated thrombocytopenia, we think about everything else is essentially a normal smear. And do the platelets look big or small, or do they look normal? Okay, so thinking about schistocytes. Whoops. All right, I'm going to try to 10. We got 10 minutes. All right. So when we think about schistocytes and spherocytes, this differential to me is always very fun to explore because schistocytes and thrombocytopenia together, the thing that it triggers in my mind is the only way I can really get schistocytes is with like intravascular hemolysis. Whereas spherocytes, to me, are when little bites of cells are taken out of the RBCs over time typically, or it's due to an intrinsic RBC defect that is going to be screened out in the extravascular space, like the spleen and the liver. So this, to me, is extravascular hemolysis. So when it comes to schistocytes, when we see these on our smear, what sort of differential comes to mind?
TTP, HUS, DIC.
TTP, HUS, DIC, anything that causes intravascular hemolysis, anything that causes microangiopathic hemolytic anemia or TMA, any of these things, anything that causes any of this can give rise to schistocytes, right? So in addition to everything that you've said, there's, you know, you can have very severe vasculitis, things that can also cause thrombotic microangiopathy, thinking about like malignant hypertension. In pregnant patients, don't forget about HELP. Or
Valves, aortic valve shearing.
Yes, exactly. So you could have intravascular shearing from like severe AS or, you know, LVADs, stuff like that. You can have it related to like autoimmune diseases other than vasculitis. So like catastrophic APLS is a common cause, not a common cause, but is linked at least to thrombotic microangiopathy. So the reason that we go into this differential is because it helps us decide what sort of workup this patient might need. So in order to work up TTP or any of these thrombotic microangiopathies, what sort of labs do we always need to look for? What do we need to rule out? And you guys said it, because you said it would have been nice to know if blank was going on with the patient when they first came in, right?
Hemolysis.
Yeah, so hemolysis labs, specifically intravascular hemolysis. So I'm going to tell you, of course, we need an LDH. What other lab helps us decide if there's intravascular hemolysis going on?
Apto.
Yeah, exactly.
Just to start, bilirubins, we should also have those.
Yeah, you could have elevated bilis, so LFTs could help, but they're not as like, you know, classically associated with intravascular hemolysis. The other things to think about are the rest of your coags and your fibrinogen, just to look at the, you know, most dangerous culprits to rule them out, right? All right, so when it comes to spherocytes, remember this is an extravascular hemolysis. So what kind of differential comes to mind when it comes to extravascular hemolysis? My hint to you is going to be, if this is, you know, microangiopathic hemolytic anemia, what sort of hemolytic anemia falls under extravascular hemolysis?
Excuse me. Why stick
You can,
Sorry, what was that?
hereditary spherocytosis.
Sure, sure. Hereditary spherocytosis. And when it comes to the type of hemolysis, the reason I'm kind of really trying to push the type of hemolysis that should come to your mind is it will trigger a differential for you. So for this, I would say that this is typically like immune-mediated hemolytic anemias. So anything that can cause like an immune-mediated hemolytic anemia, or anything, like you said, for hereditary spherocytosis, so like things that are going to cause like intrinsic RBC defects, lead to spherocytosis in the peripheral smear and can be associated with thrombocytopenia. So how do we evaluate for these sort of things? is it could be specific to the underlying mechanism, right? So what's going to be very essential for our workup is getting more history, making sure that they don't have risk factors for these immune-mediated hemolytic anemias. The other thing we always think about is hypersplenism. So doing typically these are patients that will get an abdominal ultrasound. These are patients that will definitely need LFTs to look at the bilies to see if there's hemolysis going on. And an LDH is helpful, but for extravascular hemolysis, a haptoglobin isn't as useful because there's no like intravascular free hemoglobin for it to bind. So it's like question mark, a haptoglobin isn't helpful unless there's catastrophic hemolysis that's over bearing the reticular endothelial system. All right, and dacrocytes. When we see dacrocytes or other evidence of like kind of like dysplasia, things being pushed out of the bone marrow, that's how I always think about this red blood cell, is there's little pores in the bone marrow, and if I think about a red cell being pushed out, it's being extruded, right? It's a teardrop cell. The bone marrow is crying because there's something horrible going on inside. So then when our differential comes to dacrocytes, again, apologies that I'm really rushing through this. The things that we think about here is, you know, primary bone marrow issues. And this is kind of related to what we talked about yesterday. Things like myelofibrosis, right? That's where you're going to get that leukoerythroblastic reaction. Other MPNs, specifically MDS is always worrisome. Aplastic anemia, AMLs, that sort of thing. And the beauty here is this entirety of this workup hinges on doing a bone marrow biopsy. So again, I'm hoping that this approach to thrombocytopenia is helping you narrow your differential based off of what you're actually seeing going on with your patient, and then allows us to kind of have a bit more of a thoughtful approach to the workup. All right, and when it comes to inclusions, I'm not going to talk too much about this because it's almost its own differential, but there could be inclusions in your WBCs or inclusions in your RBCs. When it comes to inclusions in WBCs that we think about, there's your human granulocytic anaplasmosis and human monocytic ehrlichiosis. And then RBC inclusions, we think about malaria and specifically also babesia. So infectious causes are always useful here, or it could be due to like some sort of spleen involvement as well. This differential right here, I'll very quickly go into as well, is any evidence of like increased WBCs or specifically like, you know, toxic granules noted in the like neutrophils or increased lymphocytes or atypical lymphocytes. This is stuff that's very much so consistent with an infection. It could be viral, it could be not viral. Things that we think about here for a differential is, what's the word I'm looking for? EBV, CMV, HIV, what's the word I'm looking for? And of course, any sort of bacterial infection, so getting just blood cultures and stuff like that. Okay, is useful for doing the workup. And then finally, and I'm sorry again that this is so quick, when it comes to your isolated thrombocytopenia, in and of itself, it's also a very interesting workup to be thinking about. So what kind of, I know that the most common cause was on everybody, tip of everybody's tongue, right? We were thinking about ITP. So this is the most common cause, but what I'll say is that it's a diagnosis of exclusion. So you have to rule out other causes of thrombocytopenia before you say that somebody has ITP. The way I think about it is triple H. So there's HIV, hepatitis, and H. pylori. And then finally, also, you need to make sure they don't have drug exposure. So drug-induced ITP is another reason. And then the platelet issue, you just think about like inborn issues like Glanzmann's or Bernard Soulier, and stuff like that. Okay, so this is our approach. Based on this differential that you end up with, you'll have an idea of what sort of additional workup to do, and when to trigger like hemolysis labs, when to trigger bone marrow biopsies, a viral evaluation, and looking for additional history, drug exposure, that kind of thing. All right, we're gonna toss it back to Alvin so he can wrap up the case in the next couple of minutes.
Okay. So as far as the ESR and CRP, those were in check. Her echo was globally hypokinetic. Her Adams TS13 was sent. They started her on plasmapheresis and prednisone. Her platelets started coming back up after a few days, and her Adams TS13 activity level from when she was admitted was undetectable. So, diagnosed for TTP.
Great. So we also forgot to mention, of course, and this hinged on my presentation, she did have schistocytes. She did have a low Adam TS13. She was treated as such. Her TTP did improve. She had some course complications where it looks like even after leaving the hospital, she came back in with like incidentally like outpatient labs noted for dropping platelets again. And she's now readmitted with a workup pending. And it seems like when she came back in, and the reason that I wanted to harp on this, which can actually help us narrow our differential. When she came back in, it looked like the outside hospital was concerned for recrudescence or recurrence of her TTP. However, she did not have schistocytes when she came here. So that tells you, based on our approach, that she doesn't have actually TTP ongoing. So we have to think about other causes of her TTP. And yeah. All right, well, thank you for sticking with me. As usual, I love going overtime. As you log off, if you have any questions, let me know in the chat or give me a ring. Thanks, guys. I just hit stop share now, right? And then I need to stop the recording. Pause.
Nice, end it.